I would like to turn things over to Terry Hill.
Thank you very much, Robbie, and thanks for stepping in for Keely. I hope it's nothing too serious. So good morning, everybody. This is Terry Hill, and I'm currently the Senior Advisor for the National Rural Health Resource Center. Our center basically has been in existence at the national level since 1995, and kind of in that capacity, we support all of the state offices of rural health, around 100 rural health networks across the country, and then do a lot of work kind of on-site in rural hospitals pretty much across the country. I've been doing this work for about 30 years and have done consulting, done work in every state that has rural hospitals. Our center, just a little bit of background, started out as a hospital network. We grew to be the State Office of Rural Health for the state of Minnesota, and then, as I mentioned, expanded in 1995 to more national contracts. So most of our funding comes from the federal government through a variety of different mechanisms. One of our largest contracts or cooperative agreements is with the Federal Office of Rural Health Policy, as I mentioned, to not only support the state offices of rural health and the Medicare State Flex programs, but also we have a very intensive presence in the Mississippi Delta region the last few years, et cetera. So today's topic is basically rural hospital movement into value in population health. And this webinar, as well as a number of workshops that were held in Nebraska, is supported by the Nebraska Office of Rural Health and their Medicare Flex program, with funding from the Federal Office of Rural Health Policy. So with that sort of introduction out of the way, I'm personally really excited to be able to introduce two of the preeminent leaders in this topic in accountable care organizations, particularly in terms of how rural hospitals have participated in accountable care organizations. And so I'm really anxious to hear what they say. As Robbie mentioned, if you have questions, put them into the chat box. And Robbie, do remind me if I overlook any of the questions, or you're welcome to basically hit *2, which will unmute your line. And as I indicated, feel free to ask those questions. We're going to have presentations by both of our speakers. But we're also going to take some time towards the end for kind of a panel discussion where I'll throw out some questions, and our panelists will give you their perspectives on those questions. But again, I do urge you, if you have questions of your own, put them into the chat box, and Robbie, I'll count on you to make sure that they're recognized. So I'm going to introduce our speakers, and I'm going to make them very brief. And what I would ask the speakers is to tell us a little bit about yourself right in the very beginning, kind of a little bit about your background and your perspective as well. So our two speakers, first is somebody that I have worked with and been a good friend of mine for years and years. She's on our National Rural Health Resource Center Board of Directors. Her name is Pat Scow, and she, for many, many years, has been the executive director of the Illinois Critical Access Hospital Network. So ICAN, as it's called, has been a national leader for years, and it's a state that's relatively close to Nebraska, which is our primary focus today. And I'm really pleased to have Pat here. She's going to begin. And then also Dr. John Finley, who's the medical director of ACO programs for Caravan Health. And Caravan Health has been kind of the preeminent leader in accountable care organizations for rural hospitals. John can tell you a little bit more about it, but literally hundreds of rural hospitals have participated in Caravan, And John is going to not only provide the perspective of those Caravan accountable care organizations, but also a physician's perspective, and talk a bit about how to get particularly primary care physicians engaged. So, and then again, I'd ask each of you to talk a little bit about who you are and kind of your perspective and your background, and then tell us more about your organization, and then anything else you're going to present. So with that, Pat, I'm going to turn things over to you. Again, thanks so much for being here. Pat, you
many of you.
Yeah, thanks.
Pardon?
I can hear you. I can hear you.
Okay, good. All right, wonderful. And we've worked with Flex program over the years together and watched it grow and launch. Many of our hospitals grow and expand, and this is exciting to see, rural hospitals moving into population health. And I want to do a shout out to Rod Triplett. I see Rod's on the line, and Rod and I have been working together on our ACO project, so it's nice. I'm glad to have Rod on board. Anyway, my task is to talk to you a little bit about what we've been doing here in Illinois and our rural hospitals and how we got involved into managing an ACO. I'm a nurse by background. I've been an administrator of a hospital, set up rural health clinics, done a variety of things, and then I was hired by the state of Illinois to roll out the critical access program, which moved into ICANN, and the hospital said we want to learn more about things, so we moved into what we call the Illinois Rural Community Care Organization, and I'll start my storyline here shortly. As in 2014, as the ACA rolled out in 2010, it started to ramp up in the 2012 and 14. We're hearing a lot about accountable care organizations, population health, and the critical access hospitals in Illinois kind of looked at me and okay, what are we going to do? How are we going to prepare for this and understand it? We really didn't have access to data. We really didn't know what we needed to do. We knew that this was a change. It was a real paradigm shift. And, our hospital said, well, we figured out how to improve our critical access. Let's figure out how we can participate in population health. So they asked ICANN to do a market share analysis of if, we had 20-some hospitals participate in some type of a shared savings, how many beneficiaries. We looked at commercial, Medicaid, and the new Medicare Shared Savings Program. The hospitals decided to go ahead with Medicare Shared Savings because they felt that we could learn with Medicare, had some protection there, with the antitrust, and they asked ICANN to manage. And bottom line, our hospitals simply said we'd rather be on the bus than not on the bus and not understanding where we needed to go. So they were willing to put their foot in the water and see what happened. So as I said, we started in 2014. We had to create an LLC to be a legal entity. And, and the ICANN organization agreed to be the parent corporation. We were initially approved as Track 1. At that time, we had 20 critical access hospitals that wanted to join in their clinics, and we had 15 independent practitioners and enough beneficiaries to get started, a board. And we did receive AIM funding in 2016. We used it really to ramp up the organization and buy some IT technology. We joined the Blue Cross Shared Savings in 2017, and then in 2018, we were approved for Track 1 again, still at risk. When we concluded 2018, we had 28,000 Medicare beneficiaries at the time with 25 CH and several small rural PPS facilities. In 2019, by adding the nurse practitioners and PAs, we went from 28 to 44,000, and Blue Cross, upped a little bit too. We know in 2020 we're going to actually add 3 more hospitals. And interesting, if you notice that we started with 15 independent practitioners, and now we're down to 4 because many of them have joined with their hospital. So this is how we look going forward. We think we potentially will have 60,000 Medicare beneficiaries, and we spread from the top of the state to the bottom of the state, from east and west. And why participate in shared savings? And once again, if you remember the statement, I said our hospitals wanted to learn. They wanted to understand population. Where our patients going? How are they using healthcare? The only way we could do it was the nice carrot that CMS gave us, and that's access to payer claims. And so we felt that was how we were going to learn. We wanted, maybe we got shared savings, maybe we didn't, but we thought we could learn, understand how we moved to value-based care, looking at performance, and eventually to other kinds of payment models. And why Rico? We felt we could leverage our numbers. We knew each other. Many of our hospitals worked together. We trusted each other. That's really important. And the hospitals were used to ICANN as our management team. We could save some costs. We had no funding up front other than each hospital agreeing to put 10 grand in. We wanted to look at population health, and we thought part of that we could find the gaps in our care by seeing the claims. So this was really their reasoning, and it's probably the reasoning today. So those of you that are familiar with ACOs and things like that, what do the claims, what do you learn from it? Where do your patients go? Provider comparisons. It's just a wealth of information. And had we not done that, we would not know about population health. We now have an idea of what are our most common diagnosis. What are our, where are patients going? Which tertiary care? Are they staying locally? What's their medication use and things like that? All that stuff. We also learned that our coding needed to be improved, and we weren't really truly representing all the chronic diseases that our patients had. We've had to learn to do deep dives. We've had to learn to do about care analytics. And to be into population health, you have to begin to understand the numbers. You have to understand when you get quality reports, when you get county rankings, when you look at, if you're an ACO, you get your cost per beneficiary. So if you take that and do a deep dive, well, is it overhead? Is the reason the cost of your group is high? Is it the hospital overhead, and your cost of healthcare in your facility? Is it the medical management? Are they ordering too many tests? Not enough tests? Is your patient going downstream for medical management where you can't control? What's your ED utilization, skilled care, outpatient cost? We've kind of described it as data mania, but whether you like it or not, we're in it. We're swimming in it, and we need to really be good at it, and that was one of the things we learned. One of the first most striking things, and we all probably knew it, is difference between in-network and out-of-network. And this probably varies from time to time, but this is just a snapshot. We use Cerner. We get our claims, and we use Cerner as our ACO data warehouse and platform, and it sorts out that we keep about 30% locally and 70% goes downstream to some kind of specialty care or skilled care. So that becomes important when you think of a rural hospital trying to control and impact change. But what's interesting, we can learn from our leakage is that we have different diagnoses that are leaving, and can we look at sepsis? Okay, in-network went out of network. Well, can we do a better job of managing that? Can we learn to keep some of those patients locally? So if you begin to think about how you understand your data and apply to your population, do we have a lot of urinary tract infections? Is that related to skilled nursing care, or is it people in their homes? And so if you're going to take care of a population and someday get one check, you've got to know your top causes, your top conditions, and how you can sort that out. And from really coming from a rural hospital perspective or a critical access or a rural provider, clinic, whatever, is our main focus is primary care. And we want to keep our patients locally. We've seen that out-migration. I just showed you an example of in and out network. And how do we keep our patients local? That's the value of the ACO information and learning about that so we can begin to manage population health. Because if it's kind of like the old Walmart, there's certain things that you're not providing at Walmart, but you want to be able to, it's the leverage. You want to be able to keep more of those things home if you're losing, hearts and other things like that. Well, what can you do more locally that keeps your hospital open and your balanced budget is? So it's how do you increase the primary care locally, and that's really important. and so in getting those patients back. I thought I might share with you what our goals are, and these are probably the main threads of an ACO, or when you get into population as an organization trying to manage. And I'm sure Dr. Findlay will kind of go into those a little bit more detail. But it's always quality score, whether we like it or not. That's how people measure us, and so we want to be good. We're working our way up. It's a challenge with so many different EMRs, but we keep working on it. We want to decrease our skilled nursing units, and you're going to see why. Specialty tracking, where are patients going, and are we getting them back? A lot of these processes have been broken over the years, and what we do in population health and ACOs is mend them, pull them together, develop a team, develop that whole local rural integrated network. We want to do Medicare well visits, find out how keep people healthy, whether they're have many health conditions or they're generally a healthy individual. We want to decrease our beneficiary costs. Okay, we put together what we call a playbook, and it takes all these particular tactics that you use to kind of build care coordination and so forth like that. And it was a way that we provided a guidebook for our hospitals, and it's a wonderful way of keeping track going on. As you'll see in a couple of my slides, is turnover that you have to deal with all the time. We know that care coordination is key to all of this, and that's what really has been fragmented over the years. And it's hard to change, and we've had to look at care coordination at the hospital, in the office, nursing homes. We've learned that, medical management is not good when it leaves our hospitals and leaves our primary care. It's very fragmented. I really like patient-centered medical home because it's kind of a guidebook for us all, and as hospital geeks, so to speak, we like conditions of participation. We like things that are clear-cut. And we certainly know that if we're going to improve things, commercial payers are looking at care coordination. We certainly always have to follow the money, whether we like it or not, but we do. And we have to realize it's not easy to change. Social determinants, local community. We've had to help our hospitals, and you get into population health, is, the visits to the emergency department. In our rural communities, we don't have multiple places for them to go. So how can we improve that? Can we open up more slots for primary care? Many of our hospitals have expanded the emergency department to have a clinic next door so that we can better provide care instead of just using the emergency department. When you're into ACOs, you learn how many times a patient uses your emergency department. It may not be yours locally, but they might be going to 3 or 4 others. It just shocks me when I think that we have a beneficiary that went to an emergency department 35 times in 1 year. So what's happening there? And a lot of those are social determinants, and it's helped us to break down. Many of our rural health clinics have added social workers, and what we haven't tackled yet is that dual eligible, and how do we better manage their care, and how do we rethink local needs. And as I said, the hospital is the hub of it, whether it's EMS, home health, and we've lost our market share, so how do we rebuild that? Our biggest challenge, as I said, the downstream spend. Rural providers, it's shifted, like particularly with inpatient surgery and outpatient surgery, and we certainly know the cost of beneficiaries. And just think, for 28,000 beneficiaries, we just estimated $12,000. That's $336 million worth of care, and are we doing the best job with that? Are we communicating and doing the best? One thing we learned from our information, and it's part of our population, is that our SNF units in our rural communities were in the bottom 95th percentile. Length of stay, cost, star ratings, and so we've really tried to hone in on our swing bed program and we want to develop a navigator program. We found that, there's just really fragmentation of the care for them. Avoidable ED visits. We're trying to figure out which hospitals have that problem and look to see, do they have an alternative for that? Can they open up a clinic? Can they expand their primary care office times? Look at our quality performance, because, whether, as I said, whether we like it or not, that's how we measure ourselves. What's the value to our medical provider? And I know Dr. Findlay will probably talk to it. It's about improving the codes, improving the reimbursement, having them around the table and learning more about, many of them did not understand what disease registries, that they could go into their EMR and pull out all their diabetic patients and look at their A1Cs and how they're being managed. And so it's begin for them to start to understand, population health. I have a chief medical officer, and he's been really critical in helping with that cultural change. And we're going to be adding a physician group advisory so that they're part of our board. We know we need to integrate them more because they're really part of it. Success stories, patient improvement. We've really reduced the ED utilization, and many of the boards look at, how come your ED utilization is going down? That's lost revenue. But we have to tell them, no, they're going to the right place. And we know that we're not going to be penalized anymore by our commercial carriers for having too high of ED utilization. The well visit, with Medicare well visits, and getting people to focus on. We've got several health coaching programs. And most importantly, what have we learned? That real skilled care patients, the care is not well coordinated. We've got patients, physicians in our rural hospitals that are providing medical care for 10, 15 nursing homes across the state. And, is there really good care going on, and how can we help improve that? How do we build a team so that people aren't lost out there? And the importance of gap care. And our rural patients are generally sicker, more chronic diseases, and you can lower your A1Cs by looking at best performance. We're seeing that care coordination, CCM is a little challenging at times. We've got patients still struggling with the copay, and we also know that our patients want to stay locally. Patient engagement is probably our biggest challenge, and that's part with chronic care management, and it's something that we have to work with every day. But we're moving the dial slowly but surely. And I think if you look at this slide in total, has it been a challenge? Oh yes, just terms and programs and cultural change and workflow and meetings and expectations and understanding a sense of urgency. And it's kind of that balancing act. But when our hospital started that journey, they wanted to learn and they wanted to understand this. So our challenges is we have like 20 different EMRs, different hospital engagement programs, limited staff being pulled. Let's say if you have a care coordinator and somebody calls in sick someplace, they get pulled. You have staff turnover. So it's really hard to build a program. And the more we see success with it, the greater the hospitals pay attention to care coordination. I spoke to a hospital board a couple of days ago with their medical staff and board, and they said, oh, we get it finally. We know we need care coordination. How do we change what we're doing? How do we that downstream spend? My husband just had bypass surgery, and I was amazed at the tertiary care center saying, well, he can't have his cardiac rehab in the local hospital. I live in a rural community, which is a critical access hospital, and I said, oh, yes, he can. I remember starting cardiac rehab there years ago. He can't have his lab and x-ray there. Do they do lab and x-ray in a small community hospital? So there's some biasness and some training and education that we have to learn. But by having data and understanding your population, we at least have information and sort out, and we can be better at trying to get those patients back. We found that nurse practitioners and physician assistants weren't assigned, and so we lost a lot of our patients, our healthy patients. So has ARECO achieved shared savings? No, but we've increased our coding scores to better reflect. We've put systems in place for population health. We've implemented care coordination. We're not as great as we'd like to be, but we know where we need to go. We've got programs in place, and these are 25 different people all working together. We've increased patient satisfaction scores. We're increasing market share. We've got a raised awareness of cost and decreased utilization. So that's, in the course of 4 to 5 years, we've lost one hospital. One hospital got out. I'll probably come back when we cycle again and move towards risk. But, that they believe in it. Our historic benchmark at the end was $12,452. We were just maybe $50 above that. But for once, our first time in 2019, first and second quarter, we've dropped almost $400 per member per month. This is CMS data. So we're finally moving the dial. It takes like 18 months for your claims to catch up for the work that you're having to do. And rural, it takes longer. We can't just snap our fingers and the change come into place. But we see that we're really on the road to recover. So I ask my CEOs over and over again, would you do it? And they say wholeheartedly yes, that they believe that they're now ready for population health and making a difference in their community. So I conclude always with my business that it's always about the patient, and that's where it has to be in rural. So thank you very much, and I'll turn it over to Dr. Finley.
Thank you.
Hello?
That's,
Okay, good. I just, there was this
there
big space of time. Thanks.
Carrie, you there? Can you hear me okay?
I am Dr. Finley, and thank you so much for being on. I'm really excited about, one of the real challenges, and we can talk a little bit more about it later, is getting our physicians involved. And you've had a perspective that I think very few, just with all the hospitals you've worked with. So I'm really happy that you're here, and I'll just turn things over to you.
Thank you, Terry, and certainly that's a tough act to follow there, Pat. You are doing remarkable work, and really you've hit on so many of the critical success factors to be successful in an ACO. So there might be some overlap here in overall principles, but I think that speaks to the fact that we're all approximating the same sort of true north. So quickly about me, I'm a family medicine physician. I had the good fortune of joining a group back in the late 90s that really was a forward-thinking group. We were doing practice transformation early on. We were one of the early CPCI awardees for family medicine, and it really enabled us to do some great work. And it's work that I've recognized now 20 years later is the great work that we're all doing today, and work such as Pat just described. So my passion is practice transformation. I did that for 15 years. 5 years prior to joining Caravan, I put on the hat of of a hospital administrator. So spent about 4 years in a critical access environment with rural health clinics as the chief medical officer, and then some time as the interim CEO. So I really understand and appreciate the struggle, not only from the trenches perspective, but also sort of from the tower, to sort of play on that, a bit of a pun there per se. But what does it take to move an entire system? What does it take to educate and move your board? And really that's where I was so excited to have the opportunity to join Caravan Health, that fundamental understanding that the struggle is real, but the end point is something, and again, as Pat concluded there, is absolutely worth it. So a little bit about Caravan. Caravan's been in this market now for just over 5 years, and really Lynn Barr, our founder, had a great vision where she recognized that many of the rural communities and rural hospitals had a pretty big hurdle and were unable to jump into the value-based world because of that 5,000 live hurdle. So she originally got together with a group of forward-thinking CEOs and was able to form some of the early small ACOs that we had focused our energy on in the 2014-15 year. Around 2016 is when we changed our focus a bit as the AIM program became available, and I'll talk about that briefly today, but really helped us to recognize the true sort of benefit of investment models to overcome that sort of second hurdle of getting into this work, which is the financial hurdle of getting an ACO off the ground, investing in that infrastructure, and making this financially doable per se for the rural communities that we all know have declining margins. In 2018, we sort of shifted our model and recognized sort of the third hurdle is the reality that there's statistical variation in the smaller ACO world, and that none of us want to take on unnecessary risk due to statistical static. And as such, we moved really a lot of our small ACOs into a large collaborative model in 2018. So today we've grown quite a bit. We've got representation all over the country. The majority of our book of business is the large collaboratives, but we also have several proprietary ACOs. And the beauty of, I think, where Caravan has evolved is what started as exclusively sort of a rural movement. We've started to build a capacity into some of those larger health systems that are working with and integrated with rural communities that are all part of their catchment area. So very happy with our success, very happy with, again, as sort of Pat mentioned, there is a strong emphasis on quality and quality reporting has enabled us to do exceedingly well in MIPS and MSSP reporting. And as such, we've continued to see great success with performance against benchmarks and have been able to pass on shared savings to many of our organizations that we work with. So that's a little bit about Caravan, and I want to shift gears now to talk a bit about, what does this what does this work look like from the provider perspective? Briefly, just again about us, our mantra is that we have to support rural communities at multiple levels. So we are a true sort of practice facilitation model where we're going to provide subject matter expertise and support everything from the clinical leader in the trenches all the way up to the administrative team, the quality individuals that are involved in quality reporting, focusing on some of those heavy lifts that are required in this work. As we all know, quality reporting, focusing on interoperability, understanding data is exceedingly difficult, and we've recognized that without access to those resources, it just becomes, again, one more hurdle for rural communities to get into this space. So we've really identified that there's a clear path to success, and really it's 3 layers, much of which, again, Pat, again, kudos to you and the work you're doing, is first and foremost is that recognition is you have to manage your patients better than fee-for-service. And fundamental to that is the sort of foundational core clinical programs that have been made available by CMS with a focus on the annual wellness visit, chronic care management, behavioral health, and other core programs to identify the population you serve and then specifically address the needs of different cohorts of patients based on complexity. And it's when you get to those high and rising risk individuals that you can really start to see that you're making an impact. So that second level is the importance of accurate coding. As we all know that these payment models in the MSSP program, which we focus on exclusively, as well as other commercial payers, we have to have an adequate understanding of who is the complexity of the patient population we serve and how can we then predict the future spend of those individuals. So we spend a fair amount of time focusing efforts on making sure that providers are getting credit for the complexity of the patients we serve. I think you all know, but the need, the clinical need, the disease severity in rural America right now is quite deep. And this is oftentimes a highly complex population. I'll talk a bit more about that later. And then third in that sort of foundation is just the importance of using data. A peer of mine had a great quote. We're used to the quote that culture eats strategy for lunch, but sort of recognition that data eats perception for lunch. So by getting data in front of frontline clinicians and health systems, you quickly can identify actionable opportunities to make a difference, not only for better cost of care, but ultimately for better patient care. As we look at this sort of pathway to success is the simple recognition, and again, a guiding mantra of myself and our Chief Medical Officer, Dr. Anna Loengard, is the recognition that primary care really is no longer a task of one. This is based on a study that was done in the Annals of Family Med a couple years back, and Duke had helped to look at this. Right now in the U.S., the average family medicine doc has about 2,300 patients. What they identified is to provide high-quality, evidence-based preventive care for that panel of patients, to do that effectively and efficiently every time so that it's the right care, the right patient, and the best care possible would take almost 22 hours a day. And I think you all recognize that that's just simply not possible. So our focus is on how you get to a high-functioning, team-based model of care. It's essential to care coordination. It's essential to the well-being of providers. And really, it's essential to sort of the core of what ACO work is about. So how do we get to that is where I want to change and focus on sort of three key elements that I think are critical to success in the ACO. First and foremost is there is a critical cultural shift that needs to occur. You have to fundamentally buy into a team-based model of care. And by that I mean that my peer group in particular and administrators have to demonstrate a willingness to move away from the sort of traditional physician-centric mindset and embrace a model that is a highly delegated model where everybody on your team is working at the top of license. This is an area that we've identified that my peer group can struggle at times, is trusting the capacity of your team and demonstrating a willingness to delegate. And in doing so, and moving away from I treat patients and there's people that help me to we treat patients together you improve access. You improve the burnout that happens in physicians every day because there's more than they can effectively manage or ever feel good about. And you remove some of the unnecessary and overly cumbersome reporting burdens that we've all recognized, and even CMS has recognized. The patients over paperwork is critical. So how do we surround the provider and that care team with the resources to make quality reporting easy, to use data analytics to help them get visibility in what they can do best? So first and foremost, you have to shift that culture to believe that a team-based model is essential. Second is capital, and again, I'm going to kind of focus back on the AIM the ACO investment model. Capital really is a catalyst, and as we all know, there's declining margins in the rural community hospitals based on a multitude of reasons, but it is critical. There's critical infrastructure that's needed to be successful. A small kind of look back at my personal history is in the CPCI grant that was awarded to us back in my private practice. It enabled us to hire the necessary staff, to increase our staffing ratio, to better manage care coordination post-discharge with post-acute providers, and et cetera. So that infrastructure is an essential first step to get that proverbial flywheel moving. There's, I've seen varying numbers around estimates of startup costs, but we know that this is a real hurdle, and it's a real reason why rural and community hospitals struggle to jump into the ring. So the AIM model that was done by CMS, they invested $80 million in 41 new and rural ACOs to move in this direction. And again, it's recognition that without these funds, it's difficult to overcome that hurdle. The results just came out, and this actually was just published in the New England Journal here in July of 2019. The AIM ACO saved $131 million in Medicare cost in 2016, looking at performance year one. And when they took back all those startup costs, the original loans, the incentive payments, and shared savings that were paid to ACOs, the net savings was $48.6 million in 2016. So participation in these programs really enabled them to overcome that initial hurdle and really focus on how do we decrease that total cost of care and be successful in that regard. So we're really excited to see that our AIM program participants in 2016 and others as noted in this study, it really did demonstrate that capital does matter, and it's a way to catalyze and move organizations in this direction. And the third one, and my last kind of key point here before I summarize, is that we've consistently found that ACO work for rural communities gives them a connection to a larger community. The work we do, and I think this is a humbling reality, but there's been recognition right now that the shortage of physicians is real, and the impact on rural is even more intense. Right now, current estimates suggest that about 1% of doctors in their final year of residency say that they want to live in a community of under 10,000 lives. And only 2% want to live in towns or communities that are 25,000 or fewer. This is a real threat and a real risk for rural communities as you look at recruitment. Having practiced my entire career in semi-rural and rural environments, I know how real the professional isolation is. And it's something that new graduates that grew up or grow up in a team-based model of care surrounded by peers really struggle with, to go into a solo practice environment or a small practice environment without team support. It really is a step back for graduates, and it's a big barrier to recruitment in rural communities. So we've identified consistently, the globe we have here is access to a larger peer network, access to visibility into an external environment. And what we do with our facilitated model is we provide teaching, coaching, and best practice sharing, and much of that is done in a peer-to-peer environment. It's access to subject matter experts that they might not otherwise have. We give them access to actionable data. where they can actually take that overly cumbersome data burden and start to focus on many of the initiatives that Pat mentioned early on. Where is network leakage going? Where are patients going when they are beyond my care to outside communities? What are the opportunities in post-acute care to really give visibility, and what do I need to do as a practicing clinician to make sure that they are getting highly coordinated care? Something that I'm very passionate about is central to family medicine philosophy is continuity of care. And as we've looked at the evolution of hospitalist and SNFist and the tendency in this country to overutilize specialists, it's become exceedingly difficult to provide highly coordinated care simply because of lack of visibility into where's your patient at. So that connection to a larger community is a critical component of the reason why physicians in rural and small community environments need to contemplate jumping into the ACO arena. And to summarize here, and Pat the same, is the true north for us all is this is about better patient care. Again, Annals of Family Med just did a really neat study looking at facilitated practice support and the move to value-based care. And there was recognition that when primary care practices get the support of a facilitator, they're 3 times more likely to implement evidence-based guidelines compared to their usual peers. And this really is a critical why, in my opinion, as a clinician. CMS did an evaluation in November of 18, and they identified that rural residents, regardless of race or ethnicity, commonly receive worse clinical care than their urban counterparts in 18 out of 33 measures. This is not to disrespect my peer group by any means, but this is the humble recognition that a team-based model is the only way we can provide high-quality, highly effective, cost-effective care in rural America. A team is what it takes to do it, and back to that Duke study in the beginning, primary care is no longer the task of one. So if my peers can recognize that in a highly delegated team, they can actually provide better care, get to more patients in their community, at the end of the day, the silver lining is that we feel better about the work we do. We've consistently seen in polling our ACO medical directors and physician leaders that the addition of a population health nurse helps them to not only provide better care to their chronically ill patients, but it also has consistently demonstrated improvements in provider well-being. So the true silver lining to me, beyond patient care, is that providers need this more than anything, and that practice transformation and system transformation, we wholeheartedly believe, is part of the solution and the reason why ACO work is so essential and vital to the future well-being of rural healthcare in our country. So I'm going to pause there and give the microphone back to you, Terry, and certainly happy to answer more questions.
Thank you very much, John and Pat. That was absolutely terrific. You know, we're learning so much, and I'm a student of this. It's my passion as well. And I can't think of 2 better speakers on this topic. So we'll have this available on our website, and hopefully the Nebraska Office of Rural Health will also make this available. So many questions come up, but one of them really is at the core of, I think, what you both talked about, and that is how do we get physicians better prepared to move into this new value-based payment system in population health. And my thought, once you talk to them, is that if they can see they have support or somehow that this is good for primary care physicians, this just seems like something that would be ideal for primary care physicians. They have help now. They are now kind of the center of the universe in the physician world. Their pay is going to go up, et cetera. Could you each address, maybe starting with John and then Pat, talk a little bit about what you're seeing with primary care physician engagement, or is there anything that you've learned as to how you get primary care physicians engaged? John?
Certainly, and great question, Terry. I think that the most important thing that organizations need to recognize, and my peer group needs to recognize, is the addition of that staff we're inherently frugal individuals. Many of us had been practice partners and managers that we were hesitant to add additional staff, but it's a bit of a fake it till you make it moment where you have to just bring on more people. And Pat, the end point is you recognize that it does enable you to do more work in any given day. In my experience working with docs, we're perfectionists by nature. And the struggle is real in the sense that you can never get to the bottom of that to-do list. So with a focus on annual wellness visits, I think of that as casting a large net and understanding who is the population you serve. It enables doctors to do better at getting to the bottom of that prevention checklist, and it enables docs the chance once a year to really get a comprehensive view of who is this patient and what is our plan as a team to treat them together. That's a heavy lift, and we just don't have time to do that in the busy day-to-day shuffle. So that AWV really adds value, and it adds to the joy of feeling like you're doing a good job. Chronic care management just quickly, our providers and peers that we work with quickly recognize that it's that between visit support that historically was uncompensated care, and it was difficult to justify spending extra time with those individuals that need it most. So the feel-good moment is, again, just recognition that we're actually doing a better job. We've consistently noted that when you have a nurse do an annual wellness visit in the conjunction with a doctor, you can get to more of those critical issues that are necessary from a prevention standpoint, as well as get to those patients just needing that extra support. So my advice to my peer group is just recognizing that your team can help you to do the work that you value most.
This is Pat. Great job, Don. I couldn't have said it any better. I would just add that what we found, in talking with physicians and practitioners, it's the workflow change, it's the logistics, and it's that cumbersome process of moving from one type of methodology or how you've been the captain of the team to being more of a team player and understanding that. It's just how do you fit in it, and just learning the process and getting the staff around you to believe that this team is together. I mean, you can't isolate the physician from this process, and I think that's what you're talking about, Dr. Finley, is just make sure that the physician's engaged and give them the opportunity, but also, it's building that workflow around it, and there's just some cumbersome, in with it. We found that, getting also the practitioners' contracts or their performance improvement incentives aligned with the ACO. If they're not aligned with the ACO, then that doesn't work either. And it's just we all have to be on the same page and have that administrative support from, the practitioner's standpoint. I think in time they begin to see the advantage. I'm not getting those multiple calls on the weekend and can't figure out what to do because they haven't taken their medicines or they're taking their insulin wrong or whatever, and they don't have oxygen and all those kinds of things that you just don't always pick up in that. To me, I found that the biggest challenge was the logistics and getting it all figured out, and I'll have, well, how am I supposed to change my things? How do I do this well visit? And it's just that learning process. And I think once they get past that, they realize that there's so much more time to their day, and they can be more engaged, and they can begin analytical. And I think what we have to do is take our information, and it looks like, John, you guys have done it, is become analytical, is how do we move to the best practice? And that's where I think we're going to keep physicians engaged moving forward, is looking at the numbers. Okay, how do we really look at the best templates in evidence-based care? And so, we're in baby steps with this. We didn't have the CPC program in Illinois, and so, it's taken us a while to kind of catch up. But love what you say, Dr. Finley.
Well, and Pat, I just have to I love what you just said, and the key is that we're so accustomed to dealing with highly complex patients in unreasonable time frames. I always talked about the game sort of hot potato, is you sort of get these patients that have tremendous needs dropped into a 10 or 15-minute slot, and it becomes overwhelming. How do I get all of this done? And what you just described is by taking the time to look at those workflows, getting through that checklist, it's a very different model where if you're a nurse or whoever your care team coordinator is, says, Dr. Finley, Mrs. Smith is in the room. She was just discharged from the hospital for a congestive heart failure exacerbation. It looks like we need a repeat of potassium because it was a bit low at discharge. I've reviewed that summary. In reviewing her preventive care plan, it also looks like she's due for mammogram and colonoscopy. You're seeing her today for this. Is there anything else that you need today? And oh, by the way, I'm going to go ahead and pull up her pneumococcal vaccine because she's due for that this year. It's a different world where all of a sudden you can spend that 10 minutes connecting with the patient and providing high quality care, analyzing what matters most in a way that you can actually do effectively in 10 minutes. And studies have demonstrated that everything you just described, Pat, is that in working on those workflows, building up your team, it actually improves the provider's capacity by about 2 to 3 patients a day. So this isn't about seeing more patients, but the reality is you can, and you can get to more patients in need day over day. And everything you said is so important. So thank you.
Pat, you mentioned long-term care and downstream spending, et cetera. I know that Caravan has documented a tremendous cost there, and also possibility of achieving more savings there as well. I also know very, very aware, if you look at the projections of Alzheimer's disease, it's scary just in terms of how many new, with the baby boomers moving into senior years and Alzheimer's, et cetera. Talk a little bit more about that. What have you been doing kind of to deal with the long-term care issues and integrating long-term care into your ACOs?
Well, I have to say it is probably our biggest challenge, and it's hard because nursing homes have to be able to pay their bills too, and it becomes a real challenge, and you want to have a collegiate relationship if you're the small rural hospital working with your 2 or 3 nursing homes in your area. So it becomes a problem, but we realize a lot of it has to do with medical management of it, and unfortunately, some of these national nursing homes have medical directors that aren't even in the state, and and all this of it. So the medical management is a problem. I think some of it's going to change a little bit in October when you have to order, when there's going to have to be medical necessity for therapies orders. We're finding that nursing homes are asking physicians to sign off on orders for patients that are over 100 years old to have PT, OT, and speech. After being in a hospital for pneumonia. I mean, some of these things just really don't make sense. And so, what we would like to propose, and we've got a demonstration project that we're ready to kick off this fall, is doing a navigator program, getting some of our providers to medically manage. And I know some of our hospitals have put nurse practitioners and PAs in the nursing homes, like clinics 2 or 3 times a week. And those things are starting to make a difference. But it takes a while because you don't want to offend the nursing home because you have to work together, but yet you've got to find out a way that benefits them. And so if we can find some way that improves their response, then we can do it. But it's really tough. We've done some also nursing home meetings with the hospitals and our team and the nursing homes, and trying to open up the communication. So it's opening up the communication, looking at our transfer communication, tackling the medical management process, putting some practitioners in there, and then I think the best thing that'll probably happen is if we can build a navigator program where the patient's really tracked all the way through. And then, really encouraging our use of our swing beds. So long answer, but it's complicated.
Yeah, and you mentioned also something that I want to touch on, and that is a lack of recognition on the part of these big tertiary care centers what is available in our critical access hospitals, including swing beds. In many cases, sending them and kind of being able to articulate the value of swing beds seems really important.
You bet. Yeah, I don't think we're doing enough of contacting our tertiary care centers and following up when patients are transferred or whatever. Part of our problem is kind of systemic problem, and I think Dr. Finley would agree, is we don't get ADTs because we're all not connected to the same EMR. So it might be your patient, but they might have gone to tertiary care, but tertiary care might have sent them to another nursing home, but yet they're assigned to your population. So there's some real faults within the system that, is a challenge for us.
Absolutely. Dr. Finley, in terms of either long-term care or another big issue, obviously, affecting the entire community is mental health and behavioral health. Can you give perspectives on how this might be affecting the ACOs and Caravan?
Absolutely, and Pat has hit on, I think, many of the key points. Again, I think that post-acute is really, we've recognized that it's one of the largest opportunities to beat your benchmark per se. I think there's been recognition that when you look at a single unit for a diagnosis, that post-acute care often is about 50% of the total cost of care for that episode of care compared to inpatient. So post-acute is an essential space, and I think that, again, Pat hit on the key components of identifying your partners. I think it's essential that you share data with your post-acute providers to make sure that they're aware of whether or not they're an outlier in ED visits, readmissions, length of stay, et cetera. I think, again, as noted, there'll be some self-correction that occurs with the payment reform occurring in that environment, but certainly a critical path to success for ACOs. In terms of, one add to that, and then behavioral health, the home health environment, I think, is equally important. And I think that recognizing, as Pat did, that the challenge is that many of these referrals into both SNF and home health environments are happening from tertiary referral centers. So it is critical that communication sort of guide the way, starting with, here's your data, what can we do to work together? You're a vital partner in our community. We want you to be successful so that we can be successful. But that really starts with your discharge planners, your hospitalists, your ED, not only in your own health system, but as you start to look at out-migration, where are your patients going? Who is the point of contact in those outside entities to start better managing them back to home? Behavioral health, gosh, Terry, that's such a big topic, and it's one that I think we all recognize the need is deep. And the resources are lean. So at least in my experience, both personally and with Caravan, is there's an absolute need for access to high quality behavioral health providers. We've recognized that many communities just simply don't have. If you look at the simple BHI program, I think that's just recognizing that, again, we can follow these individuals, and this is a rising risk population that just needs more personalized hand-holding and follow-up. It's a great sort of extension of chronic care management. Who has depression? Is it well managed? Are they in remission or not? So I think that the BHI programs, behavioral health, are easy to integrate into everyday family medicine workflows. It's just a matter of recognizing your EHR, who are patients with active diagnoses, that we need to connect with between visits to make sure that they're progressing down that path. Working closely with your behavioral health providers that are available in the community really is step 2. And I think the step 3, and that's a bit heavier lift in our experience, is identifying, who are the psychiatrists that are available that can help with medication management for those more complex patients. And I think we've identified that the psychiatric need is intense, and many communities simply don't have access. And as we start to move down that path, we've gone in the direction of having a psychiatrist available that can work in that collaborative care management model. And I think this is where the future is bright for telepsychiatric services, so that we can connect those patients, identify them, and then connect them to resources maybe outside the community for those medication consults and potentially additional therapy if applicable. But that's a tough one, Terry. We found that, I always say, just, being very frank, is it sort of that doorknob moment as a physician, where I don't think we've recognized the true significance of the impact of behavioral health conditions on utilization and total cost of care. We've clearly recognized that individuals with, depression, as an example, have 2 to 3 times greater utilization overall because they're ending up in the ED. So I think there's some low-lying fruit by just getting your BHI program off the ground and just identifying them as an at-risk cohort. And I think that is work that can be done locally. Again, I think collaborative care management is a bit heavier lift, and it's going to take some innovative strategies to move into sort of virtual models in our experience.
Well, we've run out of time here. I could go on for another hour with these two folks. I want to thank both of you, not only for speaking today, but for the incredible work you do for communities throughout rural America. And I also want to thank, the Nebraska Office of Rural Health and the Nebraska Medicare Flex program for kind of having the privilege to work in Nebraska. I really enjoyed. I learned a lot. I mean, that's the thing about going out to rural hospitals or talking to rural hospital leaders is you generally learn as much or more than you have to convey to the